afternoon. My name's Molly, and Molly Mitchell. I'm with the Mid-Atlantic Public Health Training Center, and on behalf of the Training Center and Department of Health and Mental Hygiene, I'd like to welcome you all to today's Public Health Practice Grand Rounds on environmental public health surveillance in Maryland, tracking communities, clusters, chemicals, and climate change. Before we begin today's presentation, I'd like to invite our online participants to visit our website to view our available online and face-to-face trainings. In addition to the trainings available on our website, such as public health nursing and the many archived grand rounds, our upcoming trainings include working with interpreters on June 10th, as well as cultural competency train the trainer on June 16th and 17th. For those watching online, we invite you to email your questions for the presenters at any time during this broadcast by clicking on the link on your screen. And we also ask that you please sign in so that we can better report to our federal funders who we are reaching with these webcasts. So with that, I will go ahead and introduce our speakers for today. We're really pleased and honored to have Dr. Clifford Mitchell as well as Dr. Tom Burke. Clifford Mitchell is the Assistant Director for Environmental Health and Food Protection at the Maryland Department of Health and Mental Hygiene. He joined the DHMH staff in 2006. Prior to that, he was on the faculty of the Johns Hopkins Bloomberg School of Public Health for 14 years. He is trained in occupational environmental medicine and internal medicine, and his responsibilities include regulation of hazards in food and consumer products, occupational and environmental disease surveillance, and response and preparedness involving chemicals and radiation. Dr. Thomas Burke is the Jacob I. and Irene B. Fabrikant Professor and Chair in Health, Risk, and Society, and Associate Dean for Public Health Practice and Training at the Johns Hopkins Bloomberg School of Public Health. Dr. Burke leads the school's efforts to advance public health practice through teaching, research, and policy. He is a professor in the Department of Health and Policy and Management, with joint appointments in the Department of Environmental Health Sciences and the School of Medicine Department of Oncology. He's also director of the Johns Hopkins Risk Sciences and Public Health Policy Institute. Prior to his appointment at Johns Hopkins, Dr. Burke was Deputy Commissioner of Health for the state of New Jersey. He worked closely with local, state, and federal practitioners to conduct collaborative research and assist in refining the scientific basis for public health practices. In 2007, he received the inaugural Faculty Award for Excellence in Academic Public Health Practice from the Association of Schools of Public Health. He also teaches courses in public health practice and the risk sciences, and has been awarded the Golden Apple for Excellence in Teaching 4 times. With that, I will hand the floor over to Dr. Clifford Mitchell.
Thank you, Molly. It's a pleasure to be back here. And to all my friends and colleagues in the audience, it's a pleasure to be back in the School of Public Health. I see a lot of friends and former colleagues and current colleagues, actually, in the audience, and I know there are folks online who are watching. Those of you, I should add parenthetically that those of you who were here a little earlier, apparently we broadcast some of our pregame festivities as well, which were not included in the price of admission, totally free. But what Dr. Burke and I are going to do today is actually talk a little bit about the practice of environmental health and environmental health as it's going on in the States right now. We're going to try to put in context some of the larger environmental health issues that I think confront environmental health as it's practiced in the states, as it's practiced at the federal government level, and what it means in no small measure, I think, for the training of future environmental health leaders at institutions such as Johns Hopkins. And so I do want to say that while we are going to talk about environmental public health tracking, and I will spend some time talking about that, the larger context for this discussion really is, what are we doing in environmental health today? Are we training the right folks for the right jobs in the future? How are we establishing priorities for environmental health? And some other issues that I think are germane here in academia and out in the practice world as well. So, as I said, I'll talk some about what we're doing in environmental health in Maryland and across the country. I want to talk some about environmental health surveillance and the role of environmental public health tracking, which Tom Burke was really instrumental in, and he's probably uncomfortable if I call him the father of environmental public health tracking, but he's at least a candidate for an uncle, if not fatherhood. And then, as I said, I want to talk about federal priorities, state priorities as they relate to our office at the Department of Health and Mental Hygiene, and some emerging issues. So I want to take you in some ways through one of my days and what my office is responsible for at the Department of Health and Mental Hygiene, and also talk a little bit from the perspective of the state environmental health directors. The Association of State and Territorial Health Officials, ASTO, is a group that is made up of the health officials from each of the 50 states and the territories as well. And it is really, in some ways, the policy-making body for those state health officials as a national group. The state environmental health directors are a peer group within ASTO, and we meet on a monthly basis to talk about environmental health issues in the states, what's happening, what people are doing, et cetera. So I want to put a little bit in context what the practice of environmental health looks like in the 50 states today. So there are a number of things that comprise environmental health, and you should recognize them because some of them, if not all, are things that probably some of you either taught or learned in the environmental health course in your School of Public Health, whatever that was. So one of the things that we spend a lot of time working on, and these are not in order particularly, we work on surveillance issues. There are a number of environmental health units that do both occupational and environmental health surveillance. Not all occupational health surveillance, to the extent that it goes on, is done in departments of public health or in environmental health units, but many of us do actually have that activity. In addition, there is a fair amount of environmental health surveillance that goes on, but I'm going to talk about that in more detail in subsequent slides. A lot of what the environmental health units do in most state health departments, but not all, is food protection. Usually, environmental health has food protection in a good number of the states. If it is not in food protection, if it's not in the health department, however, there are a number of states in which food protection is actually done by the Department of Agriculture. So in most cases, there's shared responsibility or primary responsibility by the health department. And this comprises, in my position, a good, in terms of FTEs, full-time equivalent employees, it's probably 70% of my full-time employees. And at the local health department level, it's a large part of what local environmental health does. Now, drinking water, another major activity. Drinking water actually is not in my purview at the state level, but at the local health department level, it's local health departments that carry out drinking water safety requirements as a delegated authority by the Maryland Department of the Environment. In a good number of states, however, health departments actually are responsible for drinking water, and that includes both public water supplies and, in some cases, private drinking water wells, which undergo routine testing. In Maryland, we do not do routine testing of drinking water wells. Those are only done when the wells are first issued. But in both cases, they are the responsibility of the Department of the Environment and then local health departments. And I am very much involved in drinking water issues as there is I work quite frequently with the Department of Environment on issues, for example, when there are boil water advisories, when there are water main breaks. There are issues that involve the local health department, the utility, the state health department, and then as the regulator, the Department of the Environment. Now, housing and sanitation are issues that are frequently the subject of local health department activities. These are again shared with housing departments or code enforcement authorities at the local health departments. But I'm actually doing some work in data collection now with some of the other health departments, looking at how much activity at the state level involves housing or indoor air quality or indoor environmental quality. Bear in mind, there is no funding at the state level, the federal level, or the local level for any activities related to indoor environmental quality, except when it comes to the workplace. There, MOSH or OSHA become involved, but at the state level and at the federal level, there is no authority. There's no statutory authority, and there's no financial resource for doing indoor environmental work. On the other hand, a fair number of calls each year, actually each month, to the state health department and to local health departments involve issues related to housing and sanitation. Lead in Maryland is actually within the purview of the Department of Environment. But it again is carried out at the local level by local health departments. And in most states, the lead programs are actually run by the state health department. And then finally, I should mention emergency preparedness. Now, there is at the state health department an Office of Preparedness and Response. That office is very responsible for things like the strategic national stockpile, pharmaceuticals that are released in the event of, for example, emergencies, like the H1N1 flu pandemic of last year and the year before. And the Office of Preparedness Response is also responsible for other public health emergencies. But as you can imagine, in the state health department and certainly at the local level, an emergency really involves all parts of the health department. And for example, I am responsible for radiologic response, so that, for example, during the recent surveillance of radiation releases, I-131 and cesium, radioactive cesium from the Fukushima reactor, the state actually did monitoring. In addition to the federal RadNet program run by EPA, the state actually has its own radiologic surveillance program, which is run by the Department of Natural Resources. The state has collectors around both Peach Bottom Nuclear Facility and the Calvert Cliffs Nuclear Facility. And those analyses are done by the state health laboratories. And so as we were looking at the spikes in I-131, still well below any public health concern, but detectable concentrations of I-131 coming from Fukushima, it was the state health department in concert with the Department of the Environment, the Department of Natural Resources, and the Maryland Emergency Management Administration, with DHMH as the lead agency in looking at those data and crafting public health and public awareness messages. So there's a lot of work that goes on in the context of environmental health. Now, I want to spend a minute talking about where the money comes from in order to do all of this work. The Environmental Health Unit at the Department of Health and Mental Hygiene has on the order of about 50 people. Those include a number of registered environmental health specialists or sanitarians, primarily in the food protection area, some in community services who are responsible for housing enforcement, youth camps, and other activities, and then a number of people who are federally funded through several grants on occupational disease surveillance and environmental public health tracking. And so if you look, this is data from all 50 states, and what these data show is that if you look across the activities that I've described, lead prevention and control, radiation emergency response, chemical emergency response, food emergency response, water, asthma, natural disasters, healthy homes, indoor air quality, and healthy communities, the blue bars represent those number of programs, the percentage of all state environmental health programs that receive some federal funding from either CDC, the Environmental Protection Agency, or other federal agencies. And as you can see, with the exception of lead prevention and control, there is no other programmatic area in which a majority of the states receive any federal funding for any of the major activities that they're engaged in. So most environmental health units run on the basis of general funds allocated by their state legislatures or fees collected by virtue of activities such as housing enforcement or primarily food activities or permits issued under various statutes such as wells, restaurants, and other food manufacturing facilities and so forth. The important point to note here is that, and I'm sure Dr. Burke will also discuss this, if you look at the direction of federal funding, both within CDC and EPA, the direction is not in an increasing direction for any of these activities. And in fact, the latest federal budget, as I'll discuss in a minute, actually has significant decreases for most of the activities in which there's already federal funding. Now, the core of public health, as you all know, is surveillance, because if we can't measure it, we can't really know what the problem is. We can't know whether or not we're fixing the problem. We can't know whether any of the policies that we're doing are actually working. And so from the 10 essential services of public health, surveillance, counting what's actually going on there, is a core function. Now, when you come to environmental health, you immediately have a problem when it comes to surveillance, because in most cases, the surveillance that is done that's relevant to environmental health actually comprises a very broad spectrum. It includes environmental monitoring, looking at hazards in the environment, and it includes health outcomes. And for those of you who are interested in biomonitoring, there's a very, very small, vanishingly small, unfortunately, area in the middle which has to do with biological dose. That is to say, how much does the population or how much does an individual, how much is the actual exposure of the individual or the population to the environmental hazard? And in most cases, as you know, what we're typically dealing with are environmental monitoring data and health outcome data, and they're generally not linked. So as Tom will discuss in detail, and so I'm not going to spend a lot of time on the genesis of this, environmental public health tracking from the point of view of state environmental health departments has been the single most important effort and the single most significant effort ever within the United States to create a system, a true system of environmental health surveillance that looks at the spectrum from environmental hazard to biological dose to health outcome, with the intention of being able to link those variables in space and in time so that we can begin to get a better sense of programmatically how we are doing with our interventions. The reason that this is critical is that if you look at the winnable battles that have been established by CDC, if you look at what I think is the major challenge facing environmental health today, the major challenge in some respects facing us is that while we all know historically that the work that we've done in environmental health has been absolutely critical and probably the single most important achievement in terms of improving lifespan, quality adjusted life years, et cetera, well beyond that of medical care, rivaled probably only by vaccines, and to that probably still less. Vaccines are probably still less in terms of efficacy than basic hygiene. But the problem has been that we haven't really done a good job of linking these data and demonstrating the effectiveness of the programs and the interventions that we've done. And if you look now at the policymakers' agenda in terms of shaping and funding health programs generally, that lack of data on the effectiveness of interventions, on where exposures are occurring, on what the health outcomes are, that vacuum is one that is being filled in some respects by a lack of funds. Because if you can't count it and you can't demonstrate its effectiveness, it's very hard to argue that it should be funded. So just a little picture of what environmental public health tracking is today. There are now 22 states and New York City which are involved in the Environmental Public Health Tracking Project. It involves a number of academic partners who are working on various aspects of the program. It has three major components: a content component, which is data, or in this case, environmental data, exposure data, and health outcomes data. Technology, which I will demonstrate in a minute, involving online analysis, visualization, and reporting of various kinds of health and environmental data. And then a large, significant effort involved in allowing people to use this resource. So let me just talk a little bit about what we're doing with environmental public health tracking here in Maryland. First of all, in terms of the structure of the program here, as in all the other states where it's been built, it comprises two large components. There's a public access, which I will demonstrate, a public portal where you can go online and see county level environmental and health data, and then a secure portal where health officers, health departments, data owners can go and look at their data in more detail, at detailed levels which are not allowed by confidentiality and privacy restrictions currently in the state. And so one of the things we're going to be talking about is the utility of this system and of these two different portals. It is the beginnings of an integrated system of looking at environmental and health data. It certainly has limitations, which I'll talk about, but if you look at the goal and its utility, one of the most important things that it can begin to do is meet a need that is expressed over and over again by communities, public policymakers, the public, and researchers, which is a one-stop shop, if you will, where you can look at a profile of a community, a profile of a county, and understand from planning purposes, for response purposes, what is the baseline level of environmental stress? What is the baseline health status of a community? And how do we think about those together? I was at a meeting yesterday, a planning meeting convened by ASTO on issues related to smart growth. And one of the questions that came up over and over again was the idea that communities are looking to be able to draw pictures of themselves and understand how much stress are they under, what's the baseline environmental load of various pollutants and so forth, and what is the baseline health status of those communities. And we're not talking about county level data, we're actually talking about community level data. And I think one of the things that states like Massachusetts and California have demonstrated is that we need to drive these data down from the county to the community level, and that's one of my big priorities for the Environmental Public Health Tracking Project in our next several years. So what I want to do is show you a little bit of where we are with the public portal and the secure portal. And so let me show you first the public portal. This is our website, which is available through DHMH. You'll see under the hot links at the front page of the Department of Health and Mental Hygiene a little link to environmental public health tracking, and it'll take you to this page where there's a description of the program, and you can then go directly from there to a series of queries in tabular fashion or maps. And this allows you essentially to build pictures of environmental and health data. So we have a number of data sets here that are being built out. Hospitalization data from Maryland's healthcare community and emergency department data are coming online. Birth defects data from the Birth Defects Registry. Blood lead levels from the Childhood Blood Lead Registry. Community water data. We also have ozone and PM 2.5 data and vital statistics data, including overall mortality and low birth weight. This allows you to look at pictures of, for example, blood lead levels across counties and by year. And you can either select individual counties or demonstrate for all counties what the years are. And so this allows you to build essentially tables that will show you the data. And these are data that are derived from the Center for Lead Poisoning Prevention at MDE, which will ultimately show you, let's see, as long as the connection is still there. And again, this is the fallibility of being like Bill Gates demonstrating the Windows 2000 when it refused to go on, the question of whether or not we've got a live link or not. So we have both tables, and we have, this depends again whether or not we're, and this looks like it's an internet connection problem here. So let me show you, while we're waiting for that to load, this is our secure portal, and this is accessible by password only because you are not allowed to view these data. What I've done is put up a simulated portal. These have simulated data on it. And so what you can see is here, hospitalization data in Maryland is collected at the zip code level. And so what you can see here are examples of asthma by zip code for the entire state. And if we have an internet connection here, you can then select, I'm waiting to see whether or not the stage is live. And apparently we don't have an internet connection. So at any rate, what you can do is generate a series of graphs and tables that allow you to see, and I'll come back to this. It just had to wake up. It will allow you to select a certain area and then build dynamically. These are calculated dynamically now. Okay, and it's looking for zip codes that don't exist, which is my problem if you go outside of the state. So let me just cancel out of this, and I'll show you now that I know that it's working. This will calculate now the rates, or maybe not, for all right. So let me try one other thing here. This is always the challenge of being live. Right. So I am having trouble with the internet connection, and I'll come back to this at some point for those of you who are interested. And here's the query. Once again, the internet seems to be a little slow. But here you can see what we've got on our public portal are both health and environmental data by county for selected years. And so what you can see here, and again, these are dynamically generated. These are rates of asthma by county for asthma hospital discharges, along with ozone concentrations. And here are the ozone concentrations. And so what you can see is this is the beginning of, and this is again our public portal. Now you can, as I showed you in the, or attempted to show you on the secure portal, you can do this at the zip code level for asthma data. For lead data, which we have at the address level, you can actually show individual cases, which is important for case management purposes. And we have as well on our secure portal, we also have available not only the data by and we also have on the available within the secure portal, we have demographic data, which includes census data, which includes housing age, housing stock, percent of people living in poverty, and so on. So what this allows you to do is essentially construct, if you are a health officer or a health department, a picture of a community or a zip code or a census tract, depending upon what the data are. And what we're essentially trying to do is give tools to health departments and the public that will allow them to understand better what the integrated picture of their community is. And I think the promise here is that as we drive these data down both on the public portal and secure portal down to the community or at least the census tract level, it will give everyone an opportunity to have a better understanding of their own community and what they are doing. And so these are the uses that I think environmental public health tracking could be used for, and is being used for across the country. From a community point of view, it's being used for community health impact assessment, which is very important in terms of environmental justice. It's important in terms of permitting of new facilities, is to have a better understanding of what's the baseline status of a community, so that if you're deciding to permit a particular facility, does that community already have a significant environmental stress load on it? Does it have an underlying health status in terms of age, in terms of morbidity, mortality, low birth weight, whatever, that would make you think twice about adding to that load, even if you don't necessarily think that there's a causal relationship between these data, which are, after all, ecological. You can still say that this is a significant or a less significant environmental stress level on this community. It's important. We've used this in terms of cluster analysis. We've used this technology along with some related analytic software to be able to look at the clustering of disease conditions. And we've done a number of projects involving questions about community level cancer using the GIS, the Geographic Information Sources, and other statistical packages in this context. And then we can also use this. One of the things that we're doing with, and other states are doing with their lead programs, is using this to better target community level interventions and to give communities a better sense for themselves of where there are problems. And finally, let me just say a word about an emerging problem. For climate change, we are talking about indicators for climate change, such as heat-related deaths or harmful algal blooms, that may be leading indicators of changes in global climate. We can also use this for a kind of a related purpose, which is as a public tool to let the public know where and when we expect to see problems emerging on a more acute basis. So that's the context of environmental public health tracking. And I leave you with that, with my apologies for the demonstration, with the idea that 22 states now have an architecture comparable to this, and there's a national tracking portal which also has data on all of the states. And as I said at the outset, this really represents an opportunity for people to understand the significance of environmental health as a discipline, because it links in time and space environmental hazards and health outcomes. And so from a community impact assessment point of view, from a planning point of view, from a smart growth point of view, from a risk communication point of view, it's probably one of the most important tools out there to be able to help bridge this gap between what we know environmental health has achieved and the perception that we've really solved all of these problems and there's really no need to fund these activities anymore because they're really done. Which is, I'm afraid, very much a problem in terms of thinking about how people are allocating resources. So let me talk about the context for this discussion. So if we talk about preparing people who are going to do environmental health in the future, I would submit to you that in terms of the bulk of what's taught in many environmental health programs, a lot of what's taught is toxicology, there's some attention to food, and then there's relatively little attention to classic sanitation and hygiene. And as I discussed with you at the outset, if you look at what the state health departments are doing in terms of their activity, it's almost the inverse, because the time spent is 85 to 95% in terms of full-time equivalent personnel, in terms of resource allocation, in terms of what people are responding to, issues related to sanitation, hygiene, food, and there is still a very significant element of toxicology, but is by no means the most important part. It's still very important, and obviously a lot of what we do in preparedness and response is related, but this is where we're spending a lot of our time, and I think that there is something of a mismatch here. If you look at the sort of traditional view of environmental health, which includes surveillance, regulation, and response, I think we are preparing people to do surveillance. We're certainly giving them the epi tools that they need. We are teaching them somewhat about responses involving emergency response, cancer investigations, and so forth. But I think we're giving them fewer of the tools that they need to carry out what is most of their activity, which is in the regulatory framework having to do with safe food, safe water, safe air, noise, something I didn't talk about in other kinds of nuisance hazards, and air conditioning, ventilation, etc. There is, I think, a need to think about where people are going to be spending their time, because this is still where the bulk of the problems come from. And so we need to be thinking about the pipeline in terms of where are the problems and where are we spending our time. So if you look at these definitions of environmental health, there's a sort of a narrow definition which classically is protection against specific hazards and specific vehicles. There's a broader definition that has more overlap. And if you think about who was in our smart growth meeting yesterday, it was departments of housing, it was lenders, it was people in housing code enforcement, it was people in transportation. And I don't have to tell you all in this audience this, but the problem is that in many, many ways, all of these folks claim some responsibility for that part of environmental health that relates to what they do. The challenge is for us to find in environmental health that part which is really specific to the health departments and the health institutions, but which informs transportation policy and, for example, housing policy. One of the questions that came to me yesterday from somebody in transportation was, look, if we give you transportation data, can you show us the public health impact of that transportation data? Because we may know things like miles of, and have data on miles of bikeways, but we don't know how to translate that into public health. And the challenge we have is we don't want to do that, we can't do that, but you can help us do that. To be able to do that requires that environmental health folks know how to talk to these folks and understand the language of engineering, the language of architecture, and so forth, but they really have to, as you all know, have basic skills that allow them to translate those data. That gets to the pipeline issue, which is that I think that there is a need to think about realigning environmental health education as it's defined by the Council on Education and Public Health and others, because I think that and I know that there is an effort to get people to think more about practicum experiences. I really think that there is, however, a mismatch in some ways between the environmental health curriculum and what environmental health is at the public level. And I think part of the way of doing that is perhaps thinking about more of the traditional internship apprentice education program model as part of, and as a fundamental part of, an environmental health trainee's experience. I would submit the same thing would be true for laboratorians, because if you look at people who are involved in the laboratory, they may do a lot of work with LCMS or GCMS-MS, but the truth is, having that practical experience in the public health laboratories for an extended period of time as part of their traineeship gives them a unique opportunity to understand how that gets applied in a way that's very difficult to understand if they don't get into the public health laboratory. And then finally, I have a challenge which is attracting people and having them come into public health. And the truth is, for a starting sanitarian or registered environmental health specialist at the local health department level in Maryland now, the starting salary is somewhere around $37,000 or $38,000. And these are people who have to have at least a college degree with a major in science. And if you look at their major competition, it's actually teaching positions. And I can't compete. It's very difficult to compete with teaching salaries. So at the same point, I've got folks who are at the doctorate and postdoctorate level who are working at the state level, who are very sophisticated laboratorians, very sophisticated food safety specialists. And even there, it's very difficult to compete and attract talented people, because when they come, they immediately get sucked up by industry or by the federal government. So there's a real challenge there for the pipeline. Let me finish by talking a little bit about national priorities. I hate to say this, for our federal partners, there's a need to have more coordination on the public health part, and I think that this is partly true, and I think a lot of that can happen through the work of academic centers. So if you look at the National Institutes for Environmental Health Science, I think there's a real challenge, for example, to get NIEHS to think more about training the public health workforce and thinking about how they can provide incentives to academic institutions to get their trainees more involved in the public health workforce. I think there's a huge need to demonstrate the effectiveness of public environmental health programs. I think the focus for legislators is, does this program save lives? Is it effective? And I think in some ways the environmental health community in the academic community have to spend more time thinking about the effectiveness at a ground level of basic core environmental health services. It's not particularly sexy, but it's a very important thing to do because the infrastructure that drives environmental health is very much at risk unless we can show how effective those programs are. And then finally, risk assessment and TSCA, one of, I know, a favorite topic here. We don't do a lot of risk assessment. Some programs do, but it's very challenging to do in the context of the day-to-day environmental health activities. It's an important tool, but it's not always the best tool for public health decision making. So with that, what I'd like to do is sort of turn things over now for the global perspective to Tom and have him think about these from a larger perspective. So thank you very much.
So thanks, Cliff, and thanks for you who are here today, even though there are 17 finals and it's the last week of the school year, and I know lots of other time pressures, and welcome to my friends on the internet too. So it's great to follow you, Cliff, because you've issued some challenges. And I think you have a unique lens on things that you and I share, of having been within the halls of academia, but also out there in the realities of public health practice in a leadership position. And so there's this disconnect. And I'd like to talk about that. I'd like to talk about the other topics a little bit today. But I think the challenge is, so how do we redefine what we're doing? This is an incredible time of change. Frankly, virtually every aspect of what we traditionally perhaps called environmental protection, environmental policy, is being questioned. It's being questioned in terms of funding. The role of our public health agencies is being questioned, and it's being challenged in terms of funding. At the same time, I think the opportunities have never been greater for us to redefine our direction and actually train the leaders of the future, because there is this kind of changing of the guard that's happening too. I don't want to mention the aging of leaders and things like that, but let's face it, it's a reality. But first, for those, particularly those who are students, and those of you who are out there and you know what I'm talking about, where else can you have this much fun? Cliff put this list up that said surveillance, food protection. Any of us have done a restaurant inspection and had a cranky owner, or anybody who's managed a bunch of inspectors and worried about things, honesty and payoffs and things like that, and the realities of managing a huge workforce. There are real challenges to this, and yet we do have the safest food, I think, any place I've ever been, and we have a remarkable track record. Now, we have a lot to do, and as a nation, we're fragmented in our approaches. But so that's food, but let's think about it. Where else can we be involved in really being almost front page every day? And Cliff is a little bit humble about this, but whether I'm watching him struggle before the news cameras on Fort Detrick, or knowing that he's involved, as he was last summer, in the rash of heat deaths, and grappling with things that don't fit those nice little boxes of organization, environmental health is the backstop for the health of the nation. Think about it. Think about who is really called upon to respond to the Japan crisis. Think about who's called upon when we have outbreaks. Think about who's doing all that work related to the floods right now, and what the environmental health implications of just providing clean water to all those folks whose wells are poisoned now will be in the future. So I hate to admit this, but environmental health people, and I know first responders too, you don't like to admit it, but when that bell goes off and you hear the sirens, there's a certain excitement about the challenge ahead and the ultimate problem solving that we all do. So So that's a little pep talk because it's still an amazing field. And I think Cliff would admit that, even though now we both have to wear shirts and ties and stuff like that. We never feel better than when we have really muddy boots and cool baseball hats on, things like that. So working in environmental health is still very challenging, but frankly, and Cliff didn't talk about this too much, if you do it well, you tick a bunch of people off. All right? Sometimes you tick off people who are trying to understand the illnesses in their children, who would really like to find an environmental cause, who have a real heartfelt feeling that the quality of their environment affects their health. And it does, but we don't understand the science behind that. Sometimes you're ticking off some big stakeholders who don't want a certain beach closed in a certain state that has 126 miles of coastline, or who have a major industry and who will use the job-killing science defense against common sense environmental protection. So we have to make environmental decisions that are very difficult, that are very challenging, particularly challenging in tough economic times. And so we'd be kidding ourselves if we thought what we learn in school can totally prepare you for the road ahead. But I think my role as the Associate Dean for Public Health Practice and Training is to really make sure we look at this horizon. We hear from our practice partners out there. Hopefully some of you are listening and will be part of the discussion so that we can better prepare people, not just doctorally trained, master trained. The best folks I've ever met in environmental health are the sanitarians, the front lines who are out there every day driving really old cars with very little tools and who don't have all that much access to the cutting edge scientific journals that would like to think from the Hopkins perspective are changing the practice of public health. So a little downer to start with. Basically, from my perspective, the glass is always half full. And it's a little challenging. I don't know what it's half full of right now, but these are tough times. And when you look at what's coming out of our associations that look at issues for state and local government, let me start at the local level. Now, we here at Hopkins, we have the Ruth Mariana, who's working with the health officers every day. The Maryland Association of County Health Officials is based here, and we hear and interact with them and their environmental health directors. And staff retention, employee morale, workloads, and costs are really draining the counties and the localities, and that there are real challenges for the retention of services. No one's saying that the water can be less safe. No one's saying that the inspections can stop. No one's saying when there's a wild raccoon in a grammar school going crazy that, oh, this is not a problem because we don't have the folks to respond to that. We're still being called upon for all those fun things I mentioned, including wild raccoons. But most people are doing more with less, with fewer workers. On the other hand, is it still fun? Is it a career opportunity? It is. It's an amazing one. Now, if you take a look at the big picture, I happen to be a member of the EPA Science Advisory Board, and it's been kind of depressing watching the funding go down and down and down for the EPA. And where it's being hit hardest, and this was from the New York Times website through the Green Wire, the kinds of cuts we're seeing now, frankly, some might say they were polluters just fantasy come true, that we're cutting back on the capability of our environmental infrastructure to really address issues of pollution and human health. But the kinds of deals and funding cuts that we're seeing actually hit state regulators and local environmental projects the worst. So I know you don't like to think about it, but the city of Baltimore has a tremendous problem in treating its wastewater and disposing of its sludge, my favorite topic there. And we need federal assistance to be able to comply with laws, to be able to safeguard the bay in our very neighborhoods, to have safe water. And these are the kind of things that are being cut back. And at CDC, we're still trying to figure out the impact. But clearly, environmental health, the National Center for Environmental Health, has received more than a 25% reduction since 2010. And the requests have potentially grave implications for programs such as environmental public health tracking. So that's the bad news. All right. So necessity is the mother of what? All right, or an invention. And I think every once in a while when I more than 2,000 employees, I would think, boy, I wish life were a little more simple and we could think about things in more manageable numbers. Not that it's a good thing to have to cut back, but it is a good thing to be challenged. Are we doing the right things? Are we teaching the right things? Are we focusing on the right priorities? And this is the time to do that. So just by way of a little background, we have been working with the practice community, as I mentioned, through the Maryland Association of County Health Officials and DHMH, and it's more terrific than ever to have Josh Sharfstein there and Fran Phillips and Cliff in leadership positions. I think we are very fortunate in Maryland to have a very, very strong public health leadership at DHMH and a wonderful and continually developing relationship with the School of Public Health. So it's terrific for us. And we've worked on environmental public health at the local level. I think most research kind of looks at the big picture and innovations in the science. But what about those program evaluations and what about the practice? How is it working? And going out and talking to all the environmental health directors and all the health officers, this is from a couple of years back, a paper that we did and a report for DHMH and the health officers to help them with environmental public health, basically looked at just how vulnerable the counties are and the state budget lines are because of the lack of dedicated funding. So that, for instance, when we have flooding, whether it's in the Inner Harbor and we have to get all those restaurants back open, as we've had, any of you who lived in Fells Point know occasionally you have to go home by kayak, and that's not good for the Red Star and the restaurants down on Thames Street, which would be called Thames in other places. But we don't have the kind of funding mechanism, so state and local folks can have core funding for those things that are so essential, and it's vulnerable. So we have to rethink things. As I mentioned, I actually think the glass is half full, even though it's a difficult time. Well, why? Because I'm continually inspired by the students who come here every year and want to go in this field, who are incredibly committed to the environment, who see things actually from a, I think, much broader perspective than many of the professors here who were more trained in discipline specific, but see the connections, connect the dots, understand the built environment, understand the issues of climate change, understand the issues of sustainability and energy use as they relate to public health. And that's the future of environmental health. We at the school have another opportunity in glass half full land now, and that we're recruiting a new chair for environmental health sciences. And that department, having gone through a review, has a chance to look at the future of its structure and its curriculum and its students. So there's lots of good things going on. Although I mentioned budget cuts, the demand for what we do has never been greater. Absolutely, there are not enough good people to go around. The infrastructure is not strong. So what's the key? Well, I actually think leadership is the key, and that people, individuals who are strong in the sciences, who are strong in the management, who are strong in the politics of environmental health can really be important. But first we got to get on the same page. All right, so public health, environmental public health just got a punch to the chin in 1970. And it wasn't intentional because Earth Day was supposed to be a good thing. But all over the nation, we structured environmental agencies outside public health agencies, and we created the first of the silos. All right. So Cliff hasn't mentioned MDE in his talk, probably because he didn't have a lot to say. How many public health folks do we have in MDE? I used to have a former student there. I'm not quite sure how it's going, but this is not to point fingers at agencies, but frankly, the culture of environmental regulation has focused on media-specific, statute-specific pollutants. The culture of environmental health is much broader than that. And as you saw with Cliff, that tracking is about the health of communities and looking at the big picture of safeguarding and improving the health of a community, and the environment being a big part of that, not this flame retardant causes this problem. That's important. It's important from a regulatory perspective to have some prevention through TSCA and those things. But we've lost that connection to public health that is so important. And we've lost it, I think, starting with our statutes and their narrow focus, and the fact that we really haven't had much progress from a regulatory perspective in about 20 years, to the cultures that have emerged that have kind of separated environmental regulators from CDC. Frankly, they don't work together. And I can say this from the safety of academia, but I've worked with all the agencies, and I've worked through the EPA, SAB, and the National Academy to try and see how we make decisions. And so this is a very old organization chart of, so who the heck does environmental health? Well, the fact is everybody. So if you're doing environmental health related to preparedness, you might be in Homeland Security or FEMA. You might be with the Department of Defense trying to figure out what's going on in Frederick County right now. You might be with the Environmental Protection Agency, but if you have an issue like fracking that's cross-cutting and needs to look at public health impacts, ecological impacts, geological impacts, economic impacts, regulatory impacts, and include stakeholders that happen to be among the most powerful on the globe, you have this challenge of the silos. Well, the good news is we don't have that at local health, and local environmental health directors get to cross-cut across those silos. So I wanted to, so Cliff accused me of being the uncle or maybe even the father of tracking. I don't want to mention Arnold Schwarzenegger, so I won't, as being accused of being a father this week. But around 2000, we were also busy at work here at Hopkins, and the Pew report on that really established environmental public health tracking. I just wanted to show this slide. It was actually the Hopkins report, but it's known as the Pew report because I was the PI on that, and we did push to work and build national infrastructure for tracking, and it is important. And here's the slide everybody knows of America's environmental health gap that said, we've lost sight of the health part of environment. It's all about the health of communities. Now, I think tracking has lost its way a little bit in a decade, and that's why I'll say I'm an uncle rather than a father, because the vision was community right to know about health. And we're not there yet, as Cliff mentioned. We haven't pushed it down from these large systems that you need secret passwords for to communities being able to understand how the environment affects their health. So in that commission report, we looked at the lack of a cohesive strategy and made recommendations that ultimately became environmental public health tracking. And I'm very happy to say that was great progress. But so why haven't we put it all together? Well, we have the agencies. I mentioned the different cultures and the Earth Day split and the laws and the missions. We have the stakeholders. Frankly, there's a lot of stakeholders, and by stakeholders I mean everyone from community members who may want to know about their health to polluters who may want to protect the status quo. The stakeholders have continued this challenge. And if you're going into environmental health and you don't understand the Restaurant Association as you try to do clean indoor air, or the grocery manufacturers as you try to tackle obesity, then you have to go back to school, or you're going to get schooled at your first public hearing in a way that is not pleasant. All right, so the science is limited. We have great uncertainty about causation. We have very little funding for, unfortunately, some of the ideologic research and epidemiology would like to see. And we haven't pulled together incentives with funding and recognizing prevention. So it is very difficult, as Cliff mentioned, to really evaluate and show, you know what? The Safe Drinking Water Act really made drinking water different in Maryland, and it reduced exposures dramatically for millions of people. Because that's not sexy research. It's important stuff. And then I'll get back to the leadership. All right. Think of who the leaders are, environmental health and the rotating kind of leadership that we unfortunately have. Now, I think health reform really might give us a new lens. And I like to try and be creative. So there's lots of things going on. There's the redefinition of public health towards sustainability and communities. But there's also this thing called health reform. Now, lots of us are worried about it because it's right in the crosshairs of a political debate, a funding debate. But imagine Just imagine that it works and we have electronic medical records and things begin to work so that we have a whole new lens on surveillance. And we don't have archaic records to try and estimate asthma and zip code levels, but we actually have timely reporting for a full range of things, from symptoms to medications to a broad range of outcomes, and we can begin to look at that picture in a new way and use surveillance in a different way. Because the fundamental problem that the Pew Commission found was that environmental health, unlike other parts of public health, lacked that fundamental data set to help us set priorities based upon human health. And I think health reform gives us those new kinds of opportunities. So I want to talk about leadership a little bit. So no programs to protect health can really happen without good leaders. And so how do we develop that? And that's Ed Baker from CDC. Because it's kind of hard to be a leader. As you can see from the faces of some prominent leaders here and nationally. So there's our namesake. He's not a happy guy. With the director of CDC. There's Josh Sharfstein doing his best to show a Hopkins conceptual framework, I think, on some public health problem. Fran Phillips talking about H1N1. Peggy Hamburg and Cliff. There he is, giving his best shot of all things environmental health for the state. It's stressful. You have to be a certain kind of person who can go from a meeting with scientists to a press conference and translate it in understandable English so that policymakers can understand and gather behind you. Now, there's also lots of good travel and event. I personally like helicopters, and some of you might know I darn near died in a helicopter over a hazardous waste site in New Jersey one time. But there is the travel and adventure part that I had to stick that in. But you might lose your hair if you do too much environmental health too. But there's also that communication thing. So Cliff, you had a nice pyramid there, inverted pyramid, but you forgot about communication. Man, try this press conference. AIDS-tainted vials on the beaches, no risk. Actually, that wasn't my headline. That isn't what I said. But we have incredible challenge of trying to put things in perspective, and communication is a really big part of that. Now, Cliff mentioned the workforce, things like recruitment and retention, and compensation. But I'd like to try and explode the myth that you can't make a decent living. Entry-level salaries are tough, but it's largely a myth that scares people away if you think you're always going to make $6,000 a year. That's not true. But we have to fight so that the food inspector is not at the end of the food chain here. And if you look at the way that geologists and others in the broader field of environmental regulation and protection are compensated, some of the people in the front lines really need, and now a lot of that is because they are funded at the state and local level and don't have the federal salaries, but we do have to take a look at that. And then there's training. So once again, we're number one in public health, and are we number one in environmental health? Are we number one in environmental health training? I think the Mid-Atlantic Training Center is a wonderful example of how we reach beyond the walls, and we provide opportunities to interact with the practice community. But we need a lot more in terms of availability, adequacy. Is it appropriate? Are we teaching the right things? Training in things like leadership and communication in those press conferences. And we have to think just how feasible will it be for us to broaden our academic approaches. Because we have, and Cliff mentioned the same word, we have now the lack of a clear pipeline of new people entering the field and a clear career trajectory for those people that is so essential to attracting folks. So it gets down to developing that toolbox, and so people taking on leadership roles have to realize that even schools of public health haven't really prepared them for everything, and that there are many, many roles, from leading the science to understanding the political climate, to administering a budget and evaluating progress, and then, of course, keeping your job. All right. So my take is success in public health requires a blend of skills that really combines a lot of competencies. Nobody has them all, but the trick is to build your strengths and recognize the talents of others who can complement your style and address the broader organizational needs. Because, in the words of Napoleon Dynamite and Pedro, I have no skills. Um, I don't know those of you who saw this movie. He didn't think he could get a date for the prom because he didn't have skills. Well, it's more than going to the prom. It's about getting things done and being a leader and having the right skills. And so, one of the things we're trying to do here at the school is take a hard look at practica, at our degree programs, and having better linkages with the actual competencies of public health practice across all of the disciplines in our departments. There will be new requirements for practica for every student who graduates from a school of public health, not just Hopkins, all of them. We have to be prepared for that. So these core competencies from the Council on Linkages, and I'll just list them really quickly, you might think, wow, how does that fit into environmental health sciences? Well, obviously assessment skills, you heard about surveillance and the importance there, but program planning skills and developing policies. I mentioned communication skills, cultural competencies. We have to work in many, many different cultures out there in environmental health, and it's very challenging. Even those doing food inspections realize, particularly, say, here in Baltimore, we have real challenges with language and translation and cultural approaches to food preparation and the indoor environment. And then the community dimensions of practice skills and leadership and systems thinking. So how do you get there? Well, I mentioned the practica, and I think that's important. I think I got pretty good doctoral education and MPH training, and that required a practicum, but I also had great mentors who told me the real world. They thought I was, not really all that effective right out of academia, and I have to admit I was, but I wasn't. But I wasn't all that effective in the first couple of years. But mentors, they make a huge difference. They might be the most important thing about training. And a good network, if you ask most people in public health practice, do you want somebody who has straight A's, who has a really good network of reaching out to the right people? They'll go with a good Rolodex, because it's all about who you're going to call when you have to make a tough choice. So for those students here and those practitioners, I think my recommendation is to get to a point where you have 4 trusted mentors. So the 4x4 approach. If you have 4 trusted mentors and 4 trusted colleagues who tell you when you're making a big mistake, who tell you what you need to improve, who can reality check things, and you've developed 4 of those core competencies from that list, you're in good shape. So, hope for the future. Well, I actually think necessity can bring positive change. It's going to depend upon new partnerships, the practica and collaboration, new training opportunities, and leadership in a time of change. So, I think, as Cliff mentioned, we need to take a look at, are our priorities straight in this time of terrible budget crisis? How do we prepare future professionals and offer training for the existing workforce that's relevant and important? Are we teaching the right stuff? Can we answer that question? Continue to build partnerships with the practice community, have more practitioners on the faculty, more students out there in the practice arena, because the students and professionals are there. It's our job to inspire them and support them. So I'll stop there and we can start our conversation. So Cliff, why don't you come on up? Over here in the dark.
Great. Thank you so much, Associate Dean Burke and Dr. Mitchell. At this time, we will be able to take questions both from our online audience and from those of you who are joining us live. Just a reminder for those who are watching the webcast, just click on your link on the screen and we will take your questions. But why don't we get started right now with those of you who are here, if you have any questions for either of our presenters. Yes.
Thank you very much for your presentations. I wanted to just ask you, Cliff and Tom, if you could perhaps think a little bit about the tracking data that you showed, Cliff, and other tracking data that's out there. And the point you made that if we don't do a very good job of environmental public health, explaining what we do and why it's successful and why it makes a difference. How can we use the data that's available now to maybe do some of that teaching, and also building the lessons on that we just learned about practicums
So I actually have some thoughts about that, and I have to say, I think the greatest lessons are the ones not where we teach history, but where we teach the present and the future and use real world examples now, despite the fact that they're messy, because I think that they're much more useful for people. So let me give you one example, and this will, I think for those of you who are involved in community-based participatory research, this is particularly relevant. You know, the Commission on Environmental Justice and Sustainable Communities, which is a Maryland commission that looks at issues of environmental justice and sustainable communities, and the folks who do smart growth and a number of other people have all been wrestling with the issue, how do you give communities a bigger voice in permitting facilities, in looking at the impacts of current facilities, and in understanding, you know, what gives communities a voice in the process of decision making. I think that there's a huge opportunity in using current data, in using tools like tracking, and in using research methodology that's focused on partnerships between communities, academic partners looking at the data, and health departments who have the data to do health impact assessments at the community level, and use those for to empower communities to do better local planning and to help us as a state do better planning around issues of facility siting, facility permitting, and so forth. And I think actually, in some ways, you know, we're the victim of our own success historically. We've done a lot of the important sanitation and hygiene things that you needed to do 50, 100, 200 years ago. What we haven't done is gone the next level, which is give people a voice now and the important questions now that they have to face. So I think that that's where there's real opportunity.
Thanks for that question, Paul. Paul directs the DRPH program in EHS, and we're all grappling with this. If you ask the students, now in some of our programs, it's a short school year like the NPH, and it's tough to get folks out there for extended internships, but those in other programs really have drawn upon the strength of the internship experience in focusing their career goals and their excitement about the field. And this is really an important part of our public health work in education. But to make it work, I didn't think it was on.
I can never tell with my voice.
No, you don't need it. No, I mean in a good way.
And I know that.
Yes. But to make it work, we have to have those effective partnerships, because an internship can be terrific and goal-directed, and we've had some of those working with Cliff and others on heat deaths in this past year with the residency program, or they can be things where it's not clearly defined. And it's incumbent upon the school to define the goals of that practica, and it's incumbent upon the departments to define just what it would take for it to be a good educational experience. But recently in my public health online practice course, we have over 100 students. I asked, how would you feel if you were required to do a practicum? And everyone voted that that's a good idea. And I was surprised, because I thought a lot of folks would say, just give me the diploma, and don't make me do more things. But I think that applied aspect is great. How we engineer this, I think little steps at a time, working with partners like Cliff, it can be terrific, but it's going to be a challenge.
Yeah.
You were talking a little bit about what the original vision was with America's environmental health gap and this sort of thing. Can you tell me a little bit about whose decision it was to password protect part of the tracking data, and why that is?
Non-IRB stuff, right?
So there's a history of that, which is actually not too complicated. We are not allowed by law to show certain data at certain levels, which is both law and policy of various data stewards. We are not the owners of these data. The health department and each program that's statutorily empowered to collect data has rules, regulations, and laws that govern what data it can release publicly. So the health department and the health officers are allowed to see data for their jurisdictions at a very local level. In fact, they can see individual cases. But for example, the way we've set this up, if you are the Frederick County health officer, you can see Frederick County data at a granular level. You can't see Wicomico County data. So it's actually necessary to password protect it. Now, I do think that, however, that certain states, and we are going to be there, I think, in the not too distant future, can drive these data down to a sub-county level, and we can do that without violating confidentiality. But we have to have, there's still a need to have a password-protected portal for the very granular data at which you can actually identify individual cases, potentially.
It's a great question. It's been a real challenge with environmental surveillance.
I know we have some more questions here. We do have some questions online, so I'd like to get to a couple of those if we can. We seem to be having a number of epidemics in our society: obesity, Alzheimer's, diabetes, autism. Do our tracking systems help us link the health challenges in our communities with the environmental component of them? And if not, how do we achieve cost-effective solutions to these issues?
So I think that there are two answers. There's my answer and there's a Tom's answer. I think the challenge for environmental public health tracking is that environmental public health tracking takes data from other surveillance systems, and there are a number of surveillance efforts going on right now to look at causes, for example, of ALS. There's an ALS registry that's out there. There are other surveillance systems that are looking at some of these other problems. I think part of the issue is tracking at its core is a system for looking at, thinking about, and linking data. I don't want to suggest that it's the only way of looking at those data. And sometimes to answer some of these questions that are really etiologic questions, causation questions, the tracking system may be very useful for looking at relationships, generating hypotheses, and helping communities understand relationships. Some of those detailed answers about what causes a certain disease, however, are going to require other kinds of investigation with other kinds of data to supplement tracking data. For example, more detailed risk factor data, confounders, et cetera. So I think tracking can be a start at looking some of those. I don't think tracking is going to give the ultimate answer to some of those. I think that will still be good old, more detailed case control studies, retrospective cohort studies, and others. But tracking has an important role to play in terms of thinking about what those relationships might be.
I think that's a good answer, but I'm impatient after 10 years. And I think the vision for tracking, well, think about 10 years ago. We didn't have enough data to know that we had an autism increase. We didn't have enough data to really accurately characterize asthma and what was going on. We have made some giant strides in baseline data, but when it comes down to community interventions or from a research perspective, having access to data to do perhaps very much needed epidemiologic investigations across jurisdictions, to look at clusters in a new way, to look at larger numbers and those things that have confounded us as researchers, to do biomarker studies. Those are the kind of things that the promise of tracking is still out there and an elusive goal. But imagine if we could put this together and we had the behavioral risk factors, we had the NHANES biomarkers, we had a new suite of environmental specific biomarkers as well as good baseline data, and we understood those at highest risk, those outside the curve, those top of the curve kind of folks. We can really begin interventions and begin to make a difference. So you're right, but I'm impatient, and I'm impatient that right now it's just kind of GIS maps of data that's somewhat old, but we'll get there. But we won't get there if we shut off the pipeline now.
Okay. We did have another question, and it really gets to how important environmental public health issues are, and yet they're the target of so many budget cuts. And do you have any ideas of how that can be addressed and why that is?
Well, I think that's a very complex question. Partly, I think that and I think that there's plenty of responsibility to go around in that. One is, I think environmental health has not done traditionally a very good job of marketing itself. Two is, I think that there has been this disconnect, just as Tom pointed out, there's a disconnect between the environmental community and the public health community on environmental health. There is also, as I think we all recognize, a disconnect between the academic environmental health community and the practice environmental health community. And so it's been difficult, whereas in for example, the traditional infectious diseases, there's very close linkage between the academic infectious disease folks and the public health infectious disease folks. The same cannot be said of environmental health, and I think that that's been to the detriment of both communities. But I think also part of the challenge is that we are now looking at a suite of problems where we're looking at longer-term preventive measures. And I think there's a certain amount of impatience, as Tom has alluded to, there's a certain amount of impatience about thinking that the results of interventions like changing physical environment, built environment today can have on obesity. We're not that patient a society that we're able to develop that evidence base and show how that works. And I think that, again, is a challenge both to the academic and to the practice community.
And I'd like to issue a broader challenge. So let's think about this school year and things that we've faced environmentally. Well, let's just start with the spill, the worst environmental release in the history of the country, with all kinds of unknown ecological and public health questions. Let's think about the issues that we've seen that perhaps, and I'm going to use perhaps, but I feel are very much related to climate change, that we see with incredibly difficult weather patterns, whether it was when some folks first got here in the summer and we saw the outbreak of heat deaths right here in our state, or whether it's the incredible precipitation and the floods that we're seeing out now in the Midwest. Think about the weather-related things. Think about climate-related things. Think about the cost of your gasoline. Think about that being an environmental issue. Think about the things that have happened around the world with the disaster, the natural disaster followed by the man-made disaster in Fukushima. And imagine, this is the year that we've cut in unprecedented numbers environmental research, occupational health research, and the National Center for Environmental Health. These are the respondents for all of those kind of things. What's wrong? Now, I realize we have lots of other things going on with the economy, but there's a huge disconnect. And I happen to think that there's indifference in the public health community and the environmental community to seeing the big picture. And it kind of annoys me. I have to say, pollution, I joke with my kids that pollution has been very, very good to you because obviously I've been employed for most of my career. But it's pretty discouraging when I spend my time in the EPA Science Advisory Board looking at a molecule, whether it's Chrome-6 or formaldehyde or dioxin, and revisiting the 30-year-old problems when we see these very broad global problems. And I challenge us as a school, I challenge us as public health practitioners to think a little bit more broadly, because people understand what's happening in the bigger environment, and we're not at the table making those decisions. To have those cuts at a time when there's such need just doesn't make sense.
Okay. Yeah, go ahead.
Dr. Mitchell, I was wondering if you could clarify or elaborate on your last comment about risk assessment. I'm curious, how are you able to manage problems if you don't do your risk assessment?
Well, I knew I would get a rise out of somebody.
I didn't even ask him to ask.
I was surprised that it went this long without a comment about my comment about risk assessment. I think that the challenge for many of us in the public health community is that risk assessment on a molecule by molecule, chemical by chemical basis is not what the public health community is confronting in practice today. What we're looking at is communities that, and this is not a surprise to you, obviously, but we're looking at communities that are confronting not an individual chemical exposure, but a whole series of chemical exposures with a whole complex series of neighborhood level epigenetic and genetic interactions. And the challenge, I think, for risk assessment is that, and I will give you one example of this, which will be painful to some of you, perhaps. The risk assessment for I-131, the drinking water guideline for I-131 was, I believe, 3 picocuries per liter, and that was based on a risk assessment which was a 70-year lifespan, 2 liter a day drinking person.
70 kilograms.
70, yeah. And the problem with that is that, we then had the EPA in the difficult position of having naturally occurring levels of I-131 in the environment far exceeding although still not significant from a public health point of view, far exceeding the regulatory level that was driven by a risk assessment. And there was an initial, I think, and I attended some of these phone calls, there was an initial discomfort on the part of the EPA because they were having cognitive dissonance. The cognitive dissonance was they have a regulatory level. They're not allowed to set a level that's higher, even temporarily, than a known regulatory level once it's adopted in regulation. And so you had an unfortunate communication problem initially, which did get sorted out. But I think the challenge is not that risk assessment is wrong. It's just that it's in some ways too simple for the world we have, and B, in the way that it's done frequently, it takes too long to get an answer that's not a practical answer for the real world. And that's not to say we shouldn't be doing it. It's just saying that from a public health perspective, from a pragmatic point of view, there are often situations where I can't wait for a risk assessment, and often when I get the risk assessment, it's not particularly helpful to me. Sorry.
But then how do you make decisions?
So-
Somewhere a risk assessment's done.
Somewhere
You may not like EPA's risk assessment, but somewhere you are interpreting data in a way that is called risk assessment.
Right. Yeah,
So-
and I think to be clear about that, you have to assess risk. Everything that we do is risk-based because we are not going to get to a zero-risk world. So the question I think that's confronting us is how do you build some flexibility into risk assessment? How do you also think about complex mixtures, complex situations in which you don't get a single risk answer? And again, I think that that's an evolution of risk assessment as well as the way we use it.
I'm going to send Cliff the silver book.
I think we have
There's-
time for one more quick question, if we haven't. Yeah.
What about
Could you wait for the mic?
somehow incorporating into the environmental health tracking program some kind of cumulative risk index where you know the facilities are where they're located and what are the different types of pollution, where you could actually have a score, and so you could to focus investigations and surveillance.
So that's a very good question, and I'm sure it's giving some people chest pain in the tracking community, but let me explain why I'm not doing that right now, and why I'm not sure that it's a good idea, actually. One is that any of you who've dealt with scores, for example, with the National Air Toxic Assessment or anything else, recognize the incredible quandary that a score represents, because it's always weighted, the weights are always judgmental, and here's my bottom line on the presentation of data in tracking right now, which is I think in some ways I want to get me out of the way of interpreting the data. I think that one of the useful things about health impact assessment and about the idea that you could have a collaboration between an academic partner, for example, like Hopkins or the University of Maryland or another institution, and a community looking at our data, is that I do not want to be the interpreter of the data. It's my weights that are being applied. And even though I know that I am totally without bias and have perfect knowledge, I try to keep that quiet because it makes for such embarrassing, press conferences later on. So I have to admit that, it's everybody brings values to the interpretation of data. And I think the job of tracking, at least for me at this point in the Maryland Tracking Project, and it's been true, I think, largely of all the other tracking programs as well, is that what we want to do is present the surveillance data and not interpret it. We do provide fact sheets on how you can think about the data. We provide metadata so that you can look at the data, understand where it came from. But at the end of the day, I think part of this challenge to all of you and to the academic environmental health community and to us as well is that I want to get people to the point where they're able to look at the data and think about what it means for themselves. And I'm happy to work with them on that, but I'm actually uncomfortable with the idea of imposing a cumulative risk score on it.
I'd back you up on that, Cliff, but we also need to have a way that the data gets used and interpreted for communities, for the research community. Because right now there's not a big line of researchers lining up to get that data. And there's so many national data sets that are uninterpreted for the American public that we really need to work harder so that it becomes useful and ultimately valued so much that it couldn't possibly be cut, that it becomes part of the fabric of public health.
Okay, thank you. I think that's, we're at the end of our time, but I really want to give so much thanks to our Associate Dean and to Dr. Mitchell for this very provocative and interesting presentation today. And thank you all for coming.
Always a pleasure, Tom.